Welcome to Research Relevant Bites. This is where we consider how to make research more relevant for theory, the practice of conducting research, communicating research, policy making, and clinical implementation, and we turn these issues into small digestible bites. I'm Stephen Shaw. I'm the chair of the Department of Educational and Counseling Psychology at McGill University. Today what we're going to tackle is the difference between clinical and statistical significance. And we tend to use these two terms interchangeably. But in fact, significant means something very different for clinical significance versus statistical significance. There are two meanings with some overlap, which makes it even more confusing because you can have something that is statistically significant and clinically significant, one or the other, or neither. So it all depends on the context and how you do this. So we'll talk about when to use it, why to use it, and why it's important for you to have as a clinician, if we're talking about clinical work, to have an evidence-based practice that is not slavishly devoted to statistical significance without much importance. Now, this happens a lot, that you have issues that are statistically significant but not important. Remember, statistical significance just vaguely refers to a finding or some result that you have being due to something other than a random event. In other words, there's something there, it's something real. But it's complicated because statistical significance is a function of sample size, measurement reliability, variance of your sample, and the effect size, the real effect. But this isn't altogether useful sometimes because there really has to be a model or a theory or a meaning or some clear value or event that you're hypothesizing. Because what tends to happen sometimes is what we do is we correlate a whole bunch of things with a whole bunch of other things, and then we pick out the 0.05s, and we'll talk about why that's important later, and call them statistically significant. But if there's no meaning or model to it, if there's no rationale for why you're doing it, it may be statistically significant, but not important. And this happens a lot. A good example is almost every nutrition study you see that says if you eat broccoli, you'll live a very long time. Usually that's a random correlation of hundreds of things people eat and the length of time people live, and finding that there's a correlation. Unless this is predicted, there's a model for it, a theory for it, it's really not particularly important. I know we put it in the newspaper, but it doesn't mean it's important. So statistical significance is only sometimes necessary, but never sufficient for clinical importance. Let me just give you an idea of this because we often hear p-value. 0.05 is the most common p-value, often referred to as alpha levels. But a p-value, alpha level is what you set ahead of time. P-value is after the fact. P-value is the probability of obtaining the test results or results of your measure at least as extreme as the results actually observed under the assumption that the null hypothesis is correct. So let's say you have two types of therapy. You have CBT and some other form of therapy. And you have maybe 30 people in each group, and you compare them. Are there differences? Now, that's not really a very good study, but nonetheless, you assume that there are no differences. That's the null hypothesis. There's no differences. And let's say you find there's a pretty big difference, or an enormous difference on average for these two groups that have it. And if those differences are big, let's just call those differences have an effect size of 2.0, meaning 2 standard deviations. So what the p-value is what's the probability, if there are no real effects, there's no difference in real life, what's the probability that this effect size of 2 actually occurred, or 2 or larger actually occurred? And usually those are really low. When you have big effect sizes, big differences, what tends to be is the probability would be certainly less than 0.05. That's kind of considered the sort of the standard metric that we use. But in some cases like 0.00001, meaning if these are really truly the same, it's very, very unlikely we will have differences as extreme as it looked. And so that's how it typically goes. For example, and this doesn't just apply to research, this also applies for, let's say you're doing it using a clinical instrument like a checklist for depression. And you use this checklist for depression and a person scores, let's say, 2 standard deviations above the mean on the depression scale. What that really means is if the person does not have depression, what's the probability that they would score 2 standard deviations above the mean? And so this is really helpful, and it's pretty rare. So the chances are, since it would be rare that if the person didn't have depression, they would score that high, we can make the case that maybe reject that null hypothesis. It seems very unlikely that's true, and far more likely that there really is depression there. And that's kind of what we look at when we look at statistical significance. And yet there's quite a bit to it. It becomes really complicated. But if we're going to use this in any real setting, we need to consider, is that important? And in the example I gave earlier, broccoli and long life, it could be very, very useful if I was doing a study that looked at people who ate broccoli and people who didn't eat broccoli, and to see if there was different in lifespan. And if I hypothesized that ahead of time and found that, no, if you eat a lot of broccoli, you'll live longer. Again, I would assume that you don't. They live the same. Broccoli and non-broccoli eaters live the same. And if there's a big difference, what's the likelihood of that occurring, with that big difference occurring or greater than that if there were no real differences? Now, if I was to do that type of test, that's fine. But when you just take hundreds of measures of food and hundreds of different ages people live to and just correlate them all in one big lump, then you can cherry pick the ones that are significant, statistically significant. Those aren't really important, though. They're just artifacts. Remember, 0.05 means there's a 1 in 20 chance that if the null hypothesis is correct, that the measures will be that big or greater. 1 in 20 means, and what if I have 500 observations? Then there's an awful lot. There's an awful lot of items that will be called statistically significant, but not important, just due to chance. The other issue is, let's say you have to make clinical judgments. You have two types of therapies. You have the CBT therapy, and you have another form of therapy, and you have an effect size, which is how big of a difference there is. Usually all these can be statistically significant depending on how big the sample size is. But an effect size of 0.2, as you see in the upper left corner there, there's really not a lot of difference. There's a huge amount of overlap between the therapy that you might use and CBT that you're comparing it to. They're kind of about the same. There's not really any true importance. Even if you look at the one in the lower right where the effect size is 2 standard deviations different, there's still a lot of overlap. The least effective therapy is still more effective than the most effective therapy for some people. So that's a hard thing, even when you have that giant effect of 2, which by the way is a ridiculously large effect, and I don't think there's any types of therapy that have effect sizes that big. But even then, there's going to be overlap. So if you use one program being statistically significantly better than another, there's really no guarantee that it's going to be a better therapy. Now, we always want something that's slightly better. We're always trying to improve incrementally, and we want to use something that's more effective. However, it's not unreasonable to use something less effective because of other factors. And that's really where that clinically importance comes into being. For example, what if you have a person who you may decide to use a less effective therapy in research, but that therapy fits in with this person's culture, it fits in with the resources available, it fits in that the client may have more buy-in with that type of therapy. Even if there's a statistically significant other issue, one might fit better. That's clinical judgment. So you don't want to be slavishly devoted to something that's clinically unimportant, but statistically significant. We look at the same on scales, measures and checklists and whatnot. If you often have items, multiple items, let's say, for example, depression, there's often 10 to 15 items that load on that depression factor. You combine all those up, and that total score gives you the whole depression factor. What if there was only one item that somebody selected on that item? Overall, they would not show evidence of depression on this. It wouldn't be statistically significant. But what if that one item was, I want to kill myself? Suicidality is something requiring intervention. It becomes extraordinarily clinically important, even though that depression scale isn't really that much different from the mean. So we need to stop being slavishly devoted to statistical significance and start considering the clinical importance of your case. Likewise, if you have an item where maybe 10 items or so, 10 items on a checklist are related to depression, some of those will be core symptoms, core critical symptoms of depression, and others will be tertiary or tangentially related to the core construct of depression. In most scales, they're weighted, all those items are weighted exactly the same. And so you really need to use professional judgment to, even if there's not a statistically significant measure of depression, they didn't reach that criteria or threshold, they still may have some of the characteristics involved. The other thing to remember is when we do research, results can be averaged out over large samples. It doesn't tell us what works best for some people in some situations because results tend to get averaged out. Usually you're comparing means, averages. And one thing to remember when you're talking about averages is that's fine for the overall group, but what researchers often call outliers, we call clients or patients. So it's quite likely that if you are working in a certain type of setting, for example, in a inpatient setting, inpatient psychiatric setting, it is quite likely that your clients may be outliers in some research and really may have even been removed from the sample because they're too different from others, in which case that research does not apply to your client or patient. So it's really important when you see research that's statistically significant that you actually look to see, is that sample the same as my sample? Is it relevant? Is my client's issue relevant to that research? So clinical importance may or may not involve statistical significance in some cases. It's really important that the judgment drive the bus. You look at it, you should have evidence-informed research or evidence-informed practice, but not slavish devotion to using what's statistically significantly better and ignoring that which is less better. You should in fact use your clinical judgment on this and make it happen. So my recommendations, just as a clinician who's comfortable with many research concepts, is to understand that nearly all clinical references should be referred to as importance. Clinically important. If it's statistically significant, for example, they reached a threshold on a measure that is statistically significant, indicating there's, assuming no pathology, what's the probability that the person, there's a low probability that the person would score that high or higher. You can call that statistical significance and then refer to that as it's also important. So you really need to differentiate that. And when you do research, if you're a researcher, be extremely humble. Remember, there's a well-established negative correlation between effect size, how big a difference there is, and study quality in almost every single field. So when you see some new therapy that comes out and it has a giant effect size, and as a therapist you go, I'm going to use that. Well, maybe not, because the quality of the study may be problematic, and that's worth looking into. The same thing, if you do a research study and you find this amazingly large effect size, be humble. There's a good probability that there's issues with study quality that may have resulted in that. So, complex process. There's a lot of complexity, but make sure every time you write significance that it is very clear whether you're talking statistical significance or clinical importance. Never should those items be in any clinical work without clearly differentiating which is what. So thank you very much for your time and energy. You can always contact me at the email above, and we'll see you on the next episode of Research Relevance Bites. Thank you very much.